Good afternoon. My name is Ariana. I'm a nephrology resident at the Hospital Corri Cabral in Lisbon. And first of all, I want to thank for the opportunity to be here. This has been 2 days of an amazing vascular access symposium. As a resident, I have learned so much in these 2 days. So for that, I thank you all. So the reason I'm here is to present this work about vascular access in patients with kidney transplant failure. So as we all know, international and national guidelines recommend the use of an arteriovenous vascular access in comparison to central venous catheter as the preferred initial vascular access. However, in Portugal, as in many other European countries, catheters still are the first vascular access in patients starting hemodialysis. And at least in Portugal, in the last years, the numbers are stable and not decreasing. So what about the kidney transplant patients with allograft failure who start hemodialysis? Well, little is known about the process of care and clinical outcomes of the vascular access in this particular population. And it would be expected, or at least I expected, that as they are closely followed by nephrologists, they are usually younger than transplant-naive patients who start hemodialysis, and that they have much higher infection risk. It would be expected to have a higher prevalence of definitive or permanent vascular access by the time that these patients start hemodialysis after kidney transplant failure. However, a recent study published in the Clinical Journal of American Society of Nephrology in 2014 shows that 66% of patients start hemodialysis with a catheter in the transplant group. And this compares with 80% of the entire population starting hemodialysis that are transplant naive. So, unfortunately, every year a significant number of patients, kidney transplant patients, had allograft failure, and these patients had to start another renal replacement therapy. In Portugal, for instance, in 2014, 119 patients suffer from allograft failure and need to start another renal replacement therapy, and the majority of the patients start hemodialysis. So the aim of this study was to determine the types of vascular access used by patients initiating hemodialysis after kidney transplant failure. This was a retrospective study, single-center study, and we analyzed all kidney transplant failure patients who started hemodialysis between January 2012 to December 2014. And so from the 69 patients, we excluded 12 due to early kidney transplant failure. So we analyzed 57 patients with mean age of 60 years. There was a male predominance, and the mean time of kidney transplant was 152 months. So what about their vascular access by the time they initiate hemodialysis? Well, the majority of patients started hemodialysis by the same vascular access that they had immediately before a kidney transplant failure. So the problem seems to be with those patients, we need a new vascular access. In this group, only 18% of patients had a permanent vascular access by the time they initiated hemodialysis, and all of them had fistula. However, a negative aspect or finding was that 26% of patients started hemodialysis by catheter. So why does these patients with kidney transplant failure start hemodialysis by catheter? We took a close look to see what could went wrong. So the first finding was that all patients had chronic allograft dysfunction, so at least all of the patients were at risk of allograft failure. Another finding was that none of them was an mTOR immunosuppressive therapy, and this is important because, as we know, these drugs delay tissue repair, and it might be a hurdle for vascular access surgery. Another important finding was that an infection intercurrence occur by the time patients return to hemodialysis in 8 of 15 patients. So it might be a hit for the anticipation of need dialysis in these patients. And the most important finding was that refer to vascular access surgery was not being made in half of the patients. So these patients that started hemodialysis by catheter after kidney transplant failure, the median time to the permanent vascular access creation was 40 days. And in 2/3 of the patients, a fistula was possible to create. So, as I said before, little is known about the process of care and clinical outcomes related to vascular access in patients that start hemodialysis after kidney transplant failure. And we observed 2 concerning and important findings. The first one is that 26% of patients initiate hemodialysis by catheter, and that half of them have not been previously referred for surgery. So why does these patients return to hemodialysis by catheter? They are closely followed by nephrologists. They are usually younger than transplant-naive patients who start hemodialysis, and they have, as we know, much higher risk of infection. So why does these patients start hemodialysis by catheter? So some of possible reasons are in the second table, where probably or possible the patients and physicians' reluctance to accept kidney transplant failure, or possible the inability to predict the trajectory of allograft failure in these patients. Sometimes a second hit become the need for the urgent dialysis, or anticipate the need for dialysis in these patients, and sometimes it is unpredictable. Is it the belief that that patient with allograft dysfunction is going to be retransplanted, and so the patients, or probably the physicians, think, oh, it's okay, it's going to be retransplanted, so maybe it doesn't need a permanent vascular access because it's going to be in a shorter time. So these are ideas or some reasons why this might happen. Another important finding was that half of the patients have not been previously referred for surgery. And we saw that the majority of patients, a permanent vascular access was possible, a fistula or a graft. I think that the published guidelines on vascular access do not specifically address recommendations on this unique population. Can we use these guidelines for chronic kidney disease and use them in patients with kidney transplant failure? So, as a conclusion, more attention to vascular access surveillance and early refer for surgery is needed in order to avoid the use of catheter in this population. Thank you all.